You can start.
Thank you, ma'am. Good evening, everyone. Today we'll be seeing how avascular necrosis of the hip masquerades as SI joint arthropathy. This happened in two cases, and I'm presenting the first one. So, a 40-year-old software engineer presented to pain medicine OPD with the chief complaints of pain in the left side of the lower back and buttock since 2 years, and the right side of the lower back since 7 to 8 months. It was more on doing activities, movements, and improves on rest. Detailed pain history is as follows. The site was the left side of lower back buttock and sometimes on the right side off and on. It was insidious, gradually progressive over the past 2 years, and the right side started developing around 7 months back. It was a dull, aching type of pain, not associated with any tingling, numbness, or any sharp shooting pain. Sometimes it radiated up to the back and outer part of the thigh, and it was there since 2 years. It was aggravated by doing daily activities, sitting, walking, wearing pajamas, etc. And it was relieved on rest and painkillers from the local doctor. There was no night pain, there was no pain at rest. He described his pain as it was not much but annoying and bothersome in the beginning and slowly started increasing with activities with a maximum of around 5 to 6 on 10. At during presentation in the OPD, his pain was almost 1 to 2 out of 10. Then he had he had hypercholesterolemia for which he was not taking any medicines. And his past medical history is that he had a history of COVID-19 in 2021. He was hospitalized and also had steroid therapy. Surgical history, no history of surgeries in the past. Pain interventions, for this same pain, he had one transforaminal epidural steroid and one SI joint injection on the left side last year in Lucknow. This gave him only minimal relief, and so the diagnostic block was negative. And social history, he's a social drinker, non smoker, and upper middle class. Negative history, there is no history of diabetes, COX, trauma, SLE, sickle cell disease, or excessive alcohol intake. On examination, he was conscious oriented, slightly obese with BMI of 40 kg per meter square. Vitals were stable and general physical examination was normal. His gait was normal, ROM of spine was normal, but in hip there was some slight restriction in both active and passive ROM. So, on examination of lower limb, muscle bulk was normal, tone was normal, temperature was not raised, there was no tenderness anywhere, and sensory examination was normal. And motor, it was 4 by 5 in the hip, 4 by 5 in the knee, and 5 by 5 in the ankle. EHL was also 5 by 5. Coming to special tests, his SLR was negative on both the sides. On the left side, Faber was positive, Gensline was also positive, Fader was also positive, but there was pain in the groin during the adduction internal rotation. And sacral thrust, pelvic distraction, and compression all were positive on the left side. And there was no spinal tenderness or SI joint tenderness. Facet loading was negative, Mackenzie was negative, and there were no sensory motor deficit. So, provisional diagnosis on history and examination with a physical examination of more than 3 by 5 for SI joint led me to come to a provisional diagnosis of SI joint arthropathy of the left side. However, there was one small confusion that the diagnostic block of SI joint done earlier at a tertiary institute was negative. So then, by thinking more, I came to a few diagnoses. I started thinking this way that it could be from the hip, spine, SI joint, or maybe some nerve entrapments. So, on any side of that side. So, coming to it could be L12 radiculopathy, it could be sacroiliitis giving the age of 40, or it could be SI joint arthropathy, degenerative, or it could be some nerve entrapments of all the nerves of that side. We were thinking of either ilioinguinal hypogastric, though it is very rare presentation, it would be more anteriorly. It could be maybe meralgia or posterior femoral cutaneous nerve or some adductor tendinosis, as he was also having some discomfort. It could also be cluneal nerve entrapment on that side. Then coming to the hip, we were thinking of maybe due to a steroid history, it could be AVN hip, osteoarthritis, or any osteomyelitis. And coming to other diagnoses like arthropathy involving the hip or SI joint, or other things like CRPS or other traumas, maybe some trivial trauma or subchondral insufficiency fracture. So then we did the investigations. The main ones were X-ray of SI joint and MRI of SI joint. So the surprise came when in the MRI of SI joint, as you can see, the SI joint is normal, but the femoral head shows some kind of lesions like bone marrow edema and some small pre-femoral head collapse. In the coronal image, we can see it more better. In the second, this one, we can see that the in the acetabulo-femoral junction, there is some collapse, pre-collapse kind of picture. So the MRI report showed that it was suggestive of AVN bilateral femoral heads, stage 3, and the iliac bones and SI joints were normal. And there was a mild hip joint effusion as well. So then his blood investigations were normal and viral markers and everything was negative. Even the inflammatory profile like ASR and CRP were normal. So now we changed our diagnosis to avascular necrosis of hip or osteonecrosis of femoral head. So then we started assessing for the factors for AVN in this patient. And as you can see, they can be direct or indirect. And in our patient, if you look at the risk factor checklist that is available, steroids, oral, IV, and IM are a definitive risk. Alcohol, not much, especially the relative risk up to 400 ml per week is 4.3 than normal population. Smoking is 3 times of non-smokers. Hypercholesterolemia is also a risk factor, and ART therapy for HIV, which was negative for him. So in our patient, he was positive for steroids as well as for hypercholesterolemia, being obese. So, coming to steroid induced osteonecrosis, we had to see if this is how does steroid contribute to osteonecrosis. So, either a cumulative high dose or a high daily dose for a small period or a very high cumulative dose for a long period, anything can cause osteonecrosis. However, in literature, there was one point that is Cushingoid features after steroid therapy is a warning sign, and there is no safe threshold dose. And this is all for prednisone. So we have to use the conversion chart of which of relative potencies of all the steroids compared to prednisone. This is how we'll come to know. Then in our patients, now that we had a definitive diagnosis of AVN, we have to go for management. As we know, management of AVN depends on its staging. So we did the FICAT and ARLET classification for this. And for him, it was stage 3, that is, there was a crescent sign. And in MRI, we didn't do the bone scan. And for the clinical symptoms, there was some pain, but there was no stiffness or limp in this patient, which is a good prognostic sign. So here we can see in our patient in stage 3, there was some head not collapse, but pre-collapse stage. That is, there was some indentation, as we saw in the MRI, there was some blackness or edema. So in this stage, our patient was in this stage, in which there is some contour differentiation. So, but FICAT and ARLET classification had some specific disadvantages in which there was no quantification. So, we also did the ARCO classification on the MRI, in which, in the ARCO classification, if there is the most important part is there is characterization of volume of the lesion, and in our patient, the volume was less than 15%, which is a good prognostic indicator. And also the lesion, as we saw, it was medial and not very lateral. So this is important because had the lesion been lateral or had it been percentage of area involvement would have been more, that is moderate or severe, we would have gone in for a surgical treatment rather than conservative. Then we also did the Harris hip score, in which we saw the pain, limp, support that was needed distance walked, and functionality of the hip joint basically. And we got it as 78, which means that it is fair. This score was traditionally used to prognosticate the prognosis after hip arthroplasty, but we also use it for follow up after interventions and to know if we can do interventions or if it was not good. If it had a poor prognosis, then we would have not done conservative and gone for THR. So it would help for the management as well as for the follow up. So coming to the management flow chart, here in a high risk population, we have already seen that his MRI was done, and in his MRI, the ARCO stage and FICAT stage was 3 early. So because it was early stage 3, we did the conservative management. We also ruled out the red flags. That is, there was no femoral head collapse or impending collapse. It was not an anterolateral lesion. Lesion volume was not more than 30% of femoral head. There was not progressive restriction of ROM. He was not developing any limp. Harris hip score was good, and age was 40, which is less, and the Kerbal angle was also less than 200. So for management, now here comes the role of interdisciplinary management, and we roped in the orthopedic team as well. And it was decided mutually that we will start on conservative management and go for a co-decompression when needed. So he was immediately started on pharmacologic therapy, physiotherapy, and we also considered regenerative therapy. Now, as we know, all pharmacologic therapy depends on pathophysiology, and here he was given vasoactive agents. As we know, AVN of the hip is due to interruption of blood flow, which causes critical ischemia and bone necrosis. So he was given vasoactive agents, bisphosphonates, statins because of his hypercholesterolemia, and also fat emboli, which can cause interruption in blood flow. And also enoxaparin was started, and we also considered BMAC. So the role of bisphosphonates is that it reduces femoral head collapse, and it's especially added in anti-cancer treatment and also on women on OCPs for this very reason. And statins, especially for chronic steroid users or especially for asthma, SLE, and COVID. And anticoagulants like enoxaparin are shown to prevent disease progression. So for him, we started OTC painkillers like paracetamol. We didn't start him on NSAIDs because we were considering regenerative therapy. Then bisphosphonates, then low molecular weight heparin was started, statins, and we did not give prostacyclin. So for physical modalities, we didn't yet start weight bearing restriction, but we started him on one cycle of extracorporeal shockwave therapy per week and considered regenerative medicine. In regenerative medicine, there are four autologous products, with three autologous products which can be used. One is platelet-rich plasma, second is growth factor concentrate, third is the bone marrow aspirate concentrate. Then also cultured osteoblasts and allogenic growth factors. So which modality will we use? So now we considered PRP versus BMAC. PRP is easy to obtain, but there is no cellular content, and the osteogenic potential of PRP is lesser than BMAC, and also the growth factors VEGF and IL-1RAP are lesser in BMAC. So we clearly thought that we should do co-decompression with BMAC, which is also better than co-decompression alone. So the references are here in the slide. And also now why BMAC? Because instead of using mesenchymal stromal cells, it has seen the total nuclear cell count of BMAC directly correlates with the MSC content. So we went ahead with that. Now the patient had one request that he wants a family function. So after co-decompression, he needs 6 weeks of no weight bearing. So for that interim period, we did this intra-articular PRP in which we did it OPD based, but in the OT and under ultrasound, and we went to the synovial tag between the head and the of the femur, between the head and the shaft of the femur, and we did the PRP of 10 billion counts of platelets approx. His was around 8.3 billion, though we aimed for 10 billion. Then after this, after 1 month of this, when the patient was ready and counseled, The orthopedic team did the core decompression and we did the BMAC through the same core decompression tunnel, and we sealed it with bone wax. After this, the patient was on no weight bearing for 4 weeks and then partial weight bearing for another 4 weeks. Now, coming to newer regenerative modalities, are there any? Yes, we have a Make in India product called autologous cultured osteoblasts, which is very much FDA and DCGI approved. And in this, extraction is taken from the bone marrow and culturing of the cells, osteoblasts, is done through specific osteogenic media, and this is implanted after the core decompression. Just as we did BMAC, we can also do implantation of osteoblasts. In this, healthy new bone is formed. And coming to studies on this, it is seen that in patients with grade 1, 2, and 3 of AVN, when they did it in 30 patients and finally could reach back to 26, only 4 progressed to grade 4 AVN, which needed THR, and the rest were well managed with conservative or regenerative therapy. Also, if a patient has COX or has malignancy or any other contraindications to autologous products, there is also human recombinant morphogenic protein 2, which is an allogenic product which we can use well in this condition, HBMP2. Then post-procedure rehab for our patients, we did no weight bearing for 4 weeks and partial weight bearing. Now it has been another 4 weeks, and he is on physiotherapy and strengthening exercises. And after procedure follow up on day 1, 10, and monthly for 3 months and 6 monthly, we look for NRS trends. He is not yet developing limp. His Harris hip score is still maintained, though with a walker. And MRI we have not yet done, will be done at the end of 1 to 1.5 years. Thank you for listening.
Thank you, Dr. Sai. That was a very good presentation. The only question I had was, did you see any symptom change when you did the PRP and you waited for 1 month for the surgery? Did he have any symptom change in that period?
He had some pain relief of MRI sorry NRS during activity, which was 6, had come down to 2. We actually also wanted to wait for some more time, but the orthopedician was like, because it is stage 3 and we are doing core decompression early stage 3, so we're doing core decompression with BMAC, so we might as well do it early because it was a team effort, so we had to do it, otherwise we could have waited.
So I was
Okay.
wondering, I mean, is there anyone in our team or anyone in the list of participants who can, Dr. Ratsers, your experience, we have done a PRP for AVN or BMAC?
For AVN of talus as well as femur head. So similarly, the ortho guys, they do core decompression. And
No, yeah, core decompression followed by bone marrow. It's I mean, I think common procedures for ortho. But do we do PRP and can just leave it like that? I mean, core decompression is needed for stage 4 for sure, but for stage 1 and 2, I know Dr. Tureja mentioned one time in one of his the conferences that they do PRP hip for AVNs. But I was wondering.
And PRP is indicated in grade 1 when there is absolutely nothing except bone marrow edema. And whenever there is bone marrow edema, even in the knee, we do intraosseous subchondral PRP. So even in AVN, it makes sense to do a subchondral or intraosseous PRP reaching up to the edema site. So when we are anyway going to use any kind of needle or drill or to reach that area, we might as well do a BMAC because we need osteogenesis, and that is given by BMAC. And
It's the standard procedures done by them.
Yes,
the procedure you did, a
was
month
BMAC.
before
I
PRP.
retrieved the BMAC and did the processing and gave it, and they did the core decompression and put it in and sealed it. It is a team effort.
With the core decompression, but 1 month before you did just the PRP, right?
I did just the PRP just to buy some time. and for pain relief. Because for pain relief, we cannot give steroids in this patient, and it is not
That makes sense.
recommended also. We might as
But
well do the PRP. One more thing about PRP is it gives a good niche. We call it something as a stem cell niche in regenerative medicine, in which before putting in the regenerative thing, you can do a PRP or a growth factor. In US, they do Prolo. They put in dextrose and then later they do the PRP. Instead, we did the PRP, did the niche, and once you put in the PRP, it attracts the pericytes of that area and changes the macrophages from M1 to M2. So this will set the cycle and you'll get a better result with BMAC.
So you can't
is
really
there any
replace the
difference?
PRP. Yeah, Divesh sir, please.
No, but is there any recommended time gap between that? Because if you do a PRP and then a BMAC, so you can plan out in that way.
Yes,
Four
if
to
you're
six
going for
weeks.
BMAC, why do PRP first?
Yeah, so we were ready to do BMAC only, but after BMAC, when you do a core decompression, you have to give the patient bed rest and no weight bearing for 4 to 6 weeks. He did not want that. He wanted to shift it for 1 month. So we did a PRP to give him the anti-inflammatory effect, pain relief, and to get a good niche so that our BMAC will act.
You
After core
wanted to buy
decompression,
some
he cannot
time.
work.
You wanted to buy some time.
Yes, for an interim procedure, we did the PRP instead of
So
anything else.
that means if you're just a routine case, if the patient is not like, then obviously there is no
We'll
need for doing
directly go for
PRP, and then
CDBMAC.
we'll
That
just
was
plan out
Uh,
for the code
that was not the case.
decompression.
They would have done
We'll
this
directly do a
procedure.
CDBMAC. Sir?
If that was not the case about the marriage or break, they would have done the procedure straightway.
Yes, had I done the procedure, he would not be able to do because for 4 to 6 weeks we have to do a complete bed rest, no weight bearing. We have did a decompression on the femoral head, so he cannot bear weight.
I'm saying if he has not sought a break of 1 month or whatever.
Then we would have directly gone for BMAX, sir.
Yeah.
So for probably for stage 1 and 2, what do you suggest? Like just the intraarticular PRP is good enough, or
No, ma'am, BMAC.
Yeah.
Because we want osteoblastic this
Yeah,
one, so
because
then we want BMAC.
the disease is going to progress in any case, so we want something even better regenerative with a because we have a
Better.
mesenchymal cells in BMAC.
So, co-decompression with BMAC has seen to delay the progress of the disease very well by as much as 9 years in literature. So, and 40 years is definitely not the age for THR. So, if we can delay it as much as we can, then we can delay his THR. That is
Actually, same
the
thing,
core concept.
because anytime he can do, because in patient obviously it will in on follow up, and the THR can be done at any point of time.
Yes,
So just the
yes,
same
yes, yes.
happened the TKR also. And then, as you said, I think the regeneration part is more with this because the chondrogenesis or those mesenchymal stems
Osteogenesis.
is a better option when you. I think same for the
Yes.
knee also. Subchondral application has a better as compared to the anything. But
Yes.
I'm worried in this case. How come that previously any what is the confusion that patient also had received some
Yeah.
low back
So,
at TFSI
actually,
and
sir, when he
during
presented last year to them, probably what a history which he was giving was that he has severe pain which is going up to the back of the thigh essay. So everybody first they suspected some radiculopathy probably because his MRI is also showing PIVD at 3 levels, L3445 and L5S1. He has good PIVD, due to which probably they did a TFASI for that. Then again he had absolutely no relief, so he went back. Now they thought that kyunki his Faber is positive, Genslen is positive, pelvic sacral thrust is positive, distraction, everything is positive. So they did a diagnostic SI joint block. There also he had no relief. Then he had actually come to the neurosurgeon for spine surgery, but neurosurgeon was not convinced, so he sent him to me. That is when, after when SI joint diagnostic block was negative, we did the MRI and then we found.
so if you say what was the that means what you're suspicious for a hip pathology in presence of sun. So what is your experience
So
or
my
with something that
take home message.
drag your diagnosis toward that or suspect?
So when
It's only
steroid
because of
intake
that exclusion or something that a history of steroid
exclusion,
young fashion,
exclusion
or
steroid intake during COVID and post-COVID uh, increase in incidence of AVN. So actually, I did MRI of SI joint and the radiologist caught it.
Yes,
so this is sort of incidental finding in
Yes,
that case.
but after this, I had one more patient in which I had only done SI joint block and it was negative.
But
Then
I
I did.
think but again,
We don't suggest to do the MRIs. You see, when the patient comes with the lower back pain, SI kind of pain, so it's not recommended to get an MRI done. They just say X-ray,
Exactly.
or
I
so.
If
think
the
that
SI
means there
joint
must be
diagnostic
some.
block is negative, then we do the MRI. Then I did the MRI, even in this case as well as the other one. But other one was
And
stage one. Yes.
this patient has a definitive history of steroid intake.
Yes, sir.
Is it
In COVID.
During COVID,
okay?
It's I mean, COVID. It's after 3 to 4 years also we are seeing the cases of avian. I mean, I had seen
But
cases
as
of
per the
avian
orthopedician, they
after
are
1 to 2 years.
but as
After
per the orthopedician, they are saying that the a sort of upward graph of the avian because of COVID and those era has now come down.
now.
They're not
Yes.
getting much of it.
Yes.
And
In
any of the
fact,
participants, if they want to say, sorry, Dr. Sai, you were saying
I
something?
asked the pulmonologist that if there's many people of any COVID with back pain or hip pain, send it, don't take it lightly. Things like that.
Any of the participants, if any questions or comments, they
Yes,
can
ma'am.
unmute themselves. Otherwise, we'll proceed to the second presentation, Dr. Mohit.
I think Dr. Duraja sir had joined in between. I think he's left. He told that he will join in between. I think during the presentation he joined. Okay, anyway, we can continue on the second one.
Yeah, he's from Artemis, Gurugram. Dr. Mohit will present on cooled RF, which they did few cases
Thank
in
you.
their
Thank
hospital.
you.
Can you share your presentation?
Ma'am, I am trying to share my presentation. Yes. Presentation visible?
Yes, you may
Yeah.
start.
Okay, good evening, everyone. Nowadays, we have seen a lot of patients, especially the elderly patients with the shoulder pain. We have seen patients with a cord stimulator in place, patient with a dislocated shoulder joint or not fit for surgery or not want to undergo surgery, or severe osteoarthritis not wanted to undergo surgery. So we had done a lot of cases with cooled radiofrequency ablation for the shoulder joint. First of all, I'll be giving a short review of the anatomy and how we did the procedure. Then the three cases, I'll give a short brief and some evidences for the cooled RFA of the shoulder joint. First of all, as we can see, uh, there is a increase in shoulder pain of the patient. It accounts for around 70% of the cases in elderly patients. And etiology is often rooted in acromioclavicular joint osteoarthritis, glenohumeral osteoarthritis, and rotator cuff pathologies. Lot of patients come to us with the impingement syndrome and partial tear or tendinosis of the rotator cuff muscles. So, a holistic approach is to undergo the cold radiofrequency ablation of the shoulder joint. Many cadaveric studies have undergone to show the nerves innervating the glenohumeral joint. The three main nerves are the suprascapular nerve, axillary nerve, and the lateral pectoral nerve. The suprascapular nerve accounts for around 70% of the innervation of the glenohumeral joint. Sorry. It supplies the posterior and the superior part of the shoulder capsule, subacromial bursa. Mhm. 1 second. Now. And the axillary nerve innervates the anterior inferior part of the joint capsule, and the lateral pectoral nerve supplies the anterior superior part of the joint capsule and the rotator cuff. As we can see in the image, the number one, the point one indicates the course of the suprascapular nerve as it passes through the sphenoglenoid notch and subsequently giving off articular sensory branches supplying the posterior medial shoulder capsule. This is the axillary nerve supplying the anterior, inferior, and the lateral part. And in the third picture, we can see the lateral pectoral nerve is supplying the anterior superior part of the joint capsule. In procedure, this is a routine which we do. We do the procedure preparation, takes consent for the patient, and most of our cases are done under fluoroscopy guidance. And in this cooled RFA, we do the procedure in supine and prone position both. First, we do the in prone position, then we make the patient supine and do in the supine position. And the cooled RF cannula, 17 gauge, 75 length with 2 active tip. We use 2 active tip. 4 active tip is also available, but to define, to give a better result, 2 is active without affecting the shoulder joint. And the procedure is done on the MAC. The target points are suprascapular nerve. The suprascapular nerve is approached in prone position. Patient's arm is by the side of the patient and it is internally rotated. In fluoroscopy, image is somewhat ipsilateral oblique and caudal with the caudal tilt. Around 10 to 15 degrees caudal tilt gives the position, and we can visualize the glenoid fossa medial to the femoral head. And we go end on to the lateral and posterior to scapula just before the glenoid fossa. And the sensory and motor tests are conducted, and the cooled radiofrequency ablation for 60 degrees for 2.5 minutes is done. As you can see in the image, this is the position for the suprascapular nerve. We do 2 lesions to cover both the branches of the suprascapular nerve side by side. For lateral pectoral nerve, the patient is positioned supine, and we usually the coracoid process is visible in the lateral and the cranial tilt with 10 to 15 degrees cranial tilt. And the cooled radio frequency cannula is introduced, and after doing the again sensory and motor testing, the lesion is done. This is the picture showing the end point for the lateral pectoral nerve. It is the tip of the coracoid process, and this is the patient of the image of the patient when we were doing the fluoroscopy under fluoroscopy. And for axillary nerve, it is also done in supine position, and the target are the inferior and the lateral edge of the greater tuberosity. Again, sensory and motor testing are done, and the lesion is performed. Yeah, as we can see in the image, the greater tuberosity, lateral and inferior point and mark to target the axillary nerve. We did 3 interesting cases. One patient, around 84-year female, she was a French teacher, online teacher, uh, with recurrent shoulder dislocation. We did cold radio frequency ablation for her. As you can see, these were the 2 targets for the suprascapular nerve. As you can see in this image also, and this is the video. Sensory and motor testing were done, and the patient confirming the for sensory. As you can see, the movement of the needle and the motor stimulation. For lateral pectoral nerve, the tip of the coracoid process. And for axillary nerve, these were the targets. This is the RF generator which we used. And the other case, the patient had spinal cord stimulator. We asked uh, for switching off the stimulator before undergoing the procedure, and it was again restarted. The same targets were used. And the third case is this is she was also an elderly female, around 80s, in her 80s. The patient had severe osteoarthritis of the humeral head, and she didn't wanted to undergo the surgery. So we did cool radiofrequency ablation, and the patient had good pain relief. Actually, she was the mother of our one of the anesthetist colleague in our Artemis only. Some These are the some evidences. There were pilot studies were done, and the conclusion was that axillary lateral pectoral and suprascapular nerve cooled radiofrequency ablation has minimal complication and is a promising alternative to treat chronic shoulder pain and stiffness for glenohumeral arthritis. Again, cooled radiofrequency ablation. This was a cohort study, and it also proved that uh, cold radiofrequency ablation improves pain and function related to shoulder pain. This is also the study. It was uh, targeting multiple shoulder nerves for chronic shoulder pain relief and functional restoration. It also said that cool radiofrequency ablation for suprascapular, axillary, and lateral pectoral nerve is safe and effective intervention. There were many studies supporting this. And then there is a study which shows that which divided the shoulder into 4 zones, and bipolar strip lesions were done in this study. These are the 4 zones: Zone A, B, C, and D. Zone A is for suprascapular nerve. Zone B is for lateral pectoral nerve. Zone C is for Zone C is Zone C is for
Zone
lateral
C is for
pectoral nerve.
lateral pectoral, yeah.
Sorry,
Zone
and
B,
Zone B is for axillary nerve.
axillary.
And they also targeted Zone D, which was for medial subacromial branch uh, and upper subscapular nerve, to give a better pain relief. These were the targets in the fluoroscopy image: Zone A, B, C, and D. So we conclude that cold radiofrequency ablation is a promising and minimally invasive alternative that could be considered for conservative management, especially for patients who are not surgical candidates or refuse surgery. And knowledge of articular sensory nerve anatomy, fluoroscopic anatomy, landmarks, and joint specific technique principles are critical to ensure technical success and good results. Thank you.
Great job, Dr. Mohit. So any specific things about positioning? I saw that the arms were on the side, and
Yes, ma'am.
anything.
Ma'am, positioning, we for that suprascapular nerve, we make the shoulder internally rotated the arm to target, so that our target gets more open, and we were able to do a goodly. We were able to approach the target.
So do you put the pillow below the chest, or
No pillow, ma'am.
just the normal
Just
prone
supine. Yeah,
position?
no normal prone position.
Okay. And axillary also you do in prone or in the supine?
Axillary
Because
in supine, ma'am. Only suprascapular we do in prone position,
prone position.
and the rest both in supine position.
Okay. And how much time do they need to get the pain relief? Is it like other RFA, 2 to 3 days, or it takes longer?
No, ma'am, it takes around, full effect comes in around for around 10 days or 2 weeks.
Okay. So we have to counsel patient accordingly.
Yeah.
Okay.
So intermittently you continue all the analgesic any specific, or how you manage the perioperative,
For
peri procedure?
perioperative, if the patient is fit for taking an anti-inflammatory, we prescribe anti-inflammatory, and post ablation we give a neuropathic medication like gabapentin or pregabalin, depending upon the patient and uh, how much she or he can tolerate.
But she must be on some, I think, previously, or none of the patient was on under any other
They are
medication prior
mostly
to
taking
this.
some anti-inflammatories like diclofenac or something. Most of the patients they have shown multiple orthopedicians and they were taking aceclofenac, diclofenac, and itracoxib.
Okay, but what about this? You straight away go for the cooled RF, or did you plan for a diagnostic block, or
No, sir.
how about,
No, we
or
didn't plan
straightforward
for
because
we didn't plan for
shoulder pain, or
diagnostic block. We straight away because going for a diagnostic block first for such for elderly patients, especially in Indian settings, and then going telling them again, after 2 days we'll do the RFA. Most of the patient will say no, we want it in one go only, under one sitting.
but I think they might not have expected the bigger needle of cooled RF also.
No, we explain the patient preoperatively only. We show images, we show them videos of how's it done.
Yeah, that is important. That means you counsel the patient, showing that is important actually, because how did you do that? Because uh, that's showing the video or something that
Yeah,
explaining that.
There's
we
one
Okay,
take
but
question
take
as
from
videos
Dr.
of
as
the.
this,
Fazil. Duration of pain relief after cooled RF.
Remember, till now we have done around 7 to 8 cases. We started last year only,
Mm-hmm.
and all our patients till now are satisfied. They have not complained for
Recurrence of
reoccurrence of
pain.
pain. Yeah.
Dr.
but do
Dinesh,
you patient comes to on your own follow-up, or do you maintain certain follow-up? Because sometimes patient doesn't come because of some constraint also. But have you
Sir,
really,
so two
so
of
that
the
do you have a broader understanding that how much duration your patient gave relief, or
sir,
average duration?
first case from starting of the first case, 1 year, around 1 year has been gone, and till now two of the cases were are from our colleagues, doctor colleagues, mothers.
Okay, that's good,
They
huh?
say, yeah, they say that she's doing well. Functional limitation is there, like the lady with severe osteoarthritis. Functional limitations, we counsel them pre-op procedure only, that we will functional improvement will not be there for such a case, but definitely they have a good
Okay.
quality of life after the procedure.
One more thing that you said, that choosing 2 active tip rather than a 4 active tip.
Uh,
Is
s-
there any specific concern that you said
Sir,
some motor blocker? How?
actually, we didn't want the lesion to be much bigger. We
But really, you that supply. Matlab, if you see, at least I think. Matlab,
sir,
for the knee, for example, we use 4 mm. So
exactly.
probably
So
because
because that
axillary,
should not be a concern.
no, but for axillary, sir, it has motor function. The axillary supplies deltoid. So probably that's why they wanted smaller lesions, just to preserve the
Get
motor
2
function.
active tip needles. I'm not sure.
That's it, आपकी आवाज कम आ
Do,
रही है.
do we get 2 active tip cooled RF needles?
Yeah,
हाँ
there
सर,
is.
दोनों हैं सर.
But normally, वो जो for the knee and all, they give 4 active tip. That
4 mm,
is
but then we're not
सबके.
concerned with the motor involvement at that time, no? So that's
Yeah,
why.
that's why, because
Sure कि वो supply करते हुए पूछूंगा उनसे. I have not seen 2 mm.
We have also not seen, and they are doing cases from last year. So we have to ask if it's available.
Yeah.
We can probably use it in cervical cases, I guess. Cooled RF. Start doing cooled RF in cervical cases.